Assalamu alaikum, everybody. So, today, inshallah, we will continue with what we have started earlier last week. We will cover the pituitary and adrenal gland disorders, as well as the pharmacotherapy for such diseases. Okay. We stopped, I think, on this slide number here, number 6 for the second go. Um, as you know, we talked about like the growth hormone. Sometimes you have either like over expression or overproduction of a growth hormone. This will result in different type of disease like gigantism or acromegaly, or sometimes people will suffer of like deficiency of a growth hormone. So we will cover both condition and what is are the possible treatment options for such diseases. Okay, so acromegaly, simply speaking, here, as you can see, we have like kind of clinical presentations that might appear on the patient who's suffering of acromegaly. Of course, these patients are in general considered like adult, so the growth for the bone already stopped. So now the feature will go or it will appear in different ways. So as you can see from the slide here, we have excessive sweating, osteoarthritis, joint pain, paresthesia, neuropathy, coarsening of facial features, prominent forehead, for example, and you can see large nose, large hand, large feet, large tongue. All of these also we can have like protrusion of the jaw, our jaw. So this also will tell that the patient is maybe suffering of acromegaly, hypertension, heart disease, cardiomyopathy, sleep apnea, type 2 diabetes. Sleep apnea, that means that during the sleep they will have cut off of the breath or abnormal breathing because of like the whole maybe the tongue is large, the teeth, the jaw is not in the correct uh, situations or position. This will lead, of course, to difficulty in breathing during the sleep and will result in sleep apnea. Um, Goals of therapy always, as you know, we measure the growth hormone response or like whether decrease or increase based on insulin like growth factor 1. Why we don't measure the growth hormone directly? Because during the day, during the week, it comes like pulsatile injections. In other ways, that the synthesis of a growth hormone is not stable all over the day. Some time in the day you might have elevated level of a growth hormone. Maybe in a couple of hours, 3 hours, you will find low level of a growth hormone. So you cannot tell exactly whether you are treating the condition or not based on the growth hormone level only. So we use a more stable form. We call it insulin like growth factor 1, and it should be normalized. Insulin like IGF-1, it should be normalized if you start treatment of these patients. Also, sorry, so you need to decrease the mortality. Of course, acromegaly could be associated with the cardiovascular complication, as we have seen earlier. So you need to decrease mortality by treating or controlling the symptoms of such disease. Also improve the clinical symptoms. Uh, Normalize IGF-1, as we mentioned, and suppress growth hormone concentration after or glucose challenge test. This, يعني, in other words, you need to bring the patient IGF-1 and the growth hormone level into normal levels, like normal subjects. Um, What are the management or the treatment of choice? Always like surgical resection of the tumor. If the reason behind acromegaly was a tumor in the pituitary gland, for example. Sometimes you can give therapy or pharmacological agent, but in general we keep them for to control the symptom before the surgery or radiation. When the surgery is not possible, then we have no option other than lifelong pharmacotherapy. Sometime in case if the surgery was not effective or we have surgical failures or relapse, then you might depend only on pharmacological options. Um, Here, the first treatment option, pharmacological options we can use for acromegaly actually, dopamine agonist, two example, bromocriptine and cabergoline. Mechanism of action, simply speaking, dopamine agonist, and you know when you have dopamine agonist drug, this will decrease the level of growth hormone in these subjects, this patient. Dosing, of course, we need to remember dosing for all the agents we will cover in this lecture as well as the previous lectures. We can start with like 1.25 milligram per day by mouth is given orally. Also, cabergoline is given orally. So, a side effect, fatigue, dizziness, nervousness, like, common side effects that might happen when you give dopamine agonist drugs. Efficacy, only 10% of the patient will get normalization of IGF-1. But when it comes to the symptoms relief, actually 50% of the subject will start feeling or experience symptomatic relief. The second options, we have somatostatin analog. Somatostatin, we know that it does block the growth hormone secretion. Okay, when you have that somatostatin analog, octreotide is like 4 times more potent than endogenous somatostatin. Usually given subcutaneously, 3 times a day. They found that you shouldn't give like dose more than 600 microgram per day if the patient actually, because you will not notice any benefit after such dose. Um, Long-acting octreotide formulation we can give once monthly, but we need to make sure that the patient is actually responding to such a treatment before we start like a long formulation octreotide. I mean the monthly one. You need to make sure that this drug actually is working in this patient. Um, the third option, or sorry, before we start, go to the third option, side effect expected somatostatin is like a hormone in your body. So it could lead to diarrhea, cramps, fat malabsorption, arrhythmia, hypothyroidism, biliary tract disorder, or can affect the glucose concentration as well. So when it comes to the efficacy, we talk about up to 60% of the patient will experience normalization of IGF-1 concentration with good symptomatic relief as well. So is these medications are considered more effective in normalization of IGF when compared to the previous medication. We talk here about like bromocriptine or cabergoline. Also, they can affect the mass or the tumor mass in some patient. So this could add like advantage to the use of such a drugs in such situation. Growth hormone receptor antagonist, we have such a drug named big Vizomant mechanism of action. It will bind to the liver growth hormone receptor and inhibit the IGF-1 release and production. It's given subcutaneously as loading dose, then we can give like maintenance dose daily. Side effect like injection site related symptoms, as well as we have flu-like symptoms, nausea, vomiting, could affect the hepatic transaminases, which are the AST, ALT, and in this case, it's good to measure to check on the liver function before you start such a treatment. Normalization of IGF-1 considered very good, excellent actually. Up to 95% of patients attain normal IGF-1 concentration, and majority, like more than 95%, get improved in their symptoms. So when it comes to which better compared to other, we consider this drug actually big measurement the best among them. Hyperprolactinemia, another topic related to what we call hypersecretory disorders of pituitary gland. Uh, the hyperprolactinemia actually, it's due to like increase the level of prolactin secretion due to different causes, maybe direct, which is like could be pituitary tumor. You know, the pituitary gland does produce prolactin hormone. Indirect cause would be like a drug induced. For example, what are the drugs that can lead to increased level of prolactin? Actually, those which works actually as antidopaminergic agents could increase the level of prolactin, like typical antipsychotics, opiate, non-dihydropyridine calcium channel blockers, as well as antidepressant agents. These drugs they can lead to hyperprolactinemia. Indirect also renal failure could be like kind of feedback mechanism. Hypothyroidism, breastfeeding could lead to hyperprolactinemia. Actually, it does lead to hyperprolactinemia breastfeeding because the main purpose sorry, for the prolactin hormone is to increase the level of milk production in those lactating women. The diagnosis and clinical presentation: elevated serum prolactin concentration, maybe challenging to find a specific cause. Unless it was a drug induced, you need to go through further investigation to check what was the reason behind hyperprolactinemia. What are the clinical presentation for patients with such problem? If we talk about female women, amenorrhea, anovulation mean they have no ovulation, a kind of infertility, hirsutism, abnormal hair growth on face or the side that which should be like low hair growth or no at all hair growth. Acne in women also could be one of the clinical presentation. Men actually erectile dysfunction, decreased libido, and gynecomastia, enlargement of male breast, reduced muscle mass. All these symptoms could be due to hyperprolactinemia among men. Headache, visual disturbances, as well as bone loss. The therapy goal: you have to bring the prolactin level to normal level, normalize gonadotropin secretion. What is the relationship between prolactin and gonadotropin? Actually, if you have a hyperprolactinemia, this will affect the gonadotropin hormone releasing hormone level and gonadotropin releasing hormone level. In other ways, we will have no FSH, no luteinizing hormone, and this will affect the gonadal function. Also, we need to relieve the symptoms mentioned earlier among either male or female. What are the treatment options? Surgery, removal of the tumor. If was the cause like a tumor-related problem, pharmacotherapy just to control the symptom before surgery. When the surgery is not possible, or we have surgical failure or relapse. If was the reason, like let's say a drug, like specific type of drug, DC for that drug. Check the level of prolactin in 3 to 5 days after discontinuation. Select agent with similar mechanism of action, but what? But no known effect on prolactin level. Okay, so you have to look other type sorry, maybe from the same family, other classes of medication, like when we talk, for example, about antipsychotic medication. We look for drugs that they are not known to cause hyperprolactinemia. Okay, if you cannot see such an agent, then you have to give another agent, which consider like dopamine agonist. In this case, actually, dopamine agonist will decrease the level of prolactin in these patients. Dopamine agonist could be used for hyperprolactinemia. Uh, Cabergoline, it's given like once weekly, so we expect like many patients will be adherent to such medication. It's just like easy uh, to take like a tablet or anything like just like once a weekly. Okay. Accordingly, it is better compared to bromocriptine because of the less GI side effect as well as long-acting oral agent. Because it is long-acting oral agent, as we may say, it is like once weekly given. Just be advised that it might restore fertility in women up to 90%. Like just like cabergoline by itself could bring back 90% of the women who are struggling with hyperprolactinemia into their normal condition, and they can easily become fertile, get pregnant. Okay. Sometime we need like to discontinue or start tapering the cabergoline dose after 2 years of therapy if the patient is symptomatic or prolactin concentration get normalized or no tumor remnant by scan showing. The case for here, what we have like now, hypersecretory problems. Here we're talking about pituitary gland hypersecretory issues. One of the major diseases is the growth hormone deficiency. Growth hormone deficiency. So we have low level of growth hormone. In general, diagnosis is depending on like different investigation process, images, lab tests, different types of measurements have to be taken to tell that the patient is having like growth hormone deficiency. For example, some drugs like arginine or clonidine, these drugs actually they should stimulate the level of a gonadotropin, growth hormone releasing hormone, okay, and decrease the level of somatostatin. Then expected that the growth hormone should go up the level. While so if you have a growth hormone deficiency, actually, this not gonna work. So other agents that we use sometimes, L-arginine, that you can also administer to patient and tell whether the growth hormone actually is increasing or decreasing, or sorry, no change. Then you can tell if there is no change that the patient is suffering of growth hormone deficiency. Sorry. What are the clinical presentation? For growth hormone deficiency, we have delayed in growth velocity or short stature. Of course, طول البيشنت مش بالطول المناسب، قصير القامة جدا. Central obesity, immaturity of the face or prominence of the forehead. How to treat, or what are the therapy goals before how to treat? Increase the growth velocity, of course, and the final goal, increase final adult height when treating children. Dosing of the growth hormone, recombinant actually growth hormone, we call somatotropin. By the way, Before we continue, I will share with you a link for noditropin, which is one of the engine drugs used for considered component to growth hormone. Maybe you can get more details from the website about the dosing, what are how to calculate the target height, or tell the patient is actually improving or not improving, how to adjust the dose based on which disease, etc. Okay, so I will share it with you later, uh, and we will talk about it next Sunday. So here, let's continue with dosing. So dosing actually depend whether you are talking about sub-Q or IM product. All of them actually effective. Okay, can be given in debut formulations like once or twice monthly, but also can be given on a daily basis. Okay. Um, Side effect for this agent, arthralgia, injection site pain, could be also like severe life-threatening side effect, idiopathic intracranial hypertension have been reported among those patients who are taking growth hormone. We have two ways. Either you go by weight or non-weight based regimen. So as you can see, based on the weight, not more than 0.004 milligram per kg sub-Q once daily, or and the maximum dose 0.016 milligram per kg once a day. Non-weight based regimen, just like directly give zero point 0.2 milligrams sub-Q once daily. Okay, and that's it. So either you go by weight or non-weight. Of course, when I will share with you the product node token, you can tell there's like a weekly based on weekly dose, or you calculate daily dose. Also, we have different diseases that we can use somatropin for such diseases like Turner syndrome, not only growth hormone deficiency, Turner syndrome, Noonan syndrome, as well as other type of growth hormone deficiency diseases. Of course, the weekly dose should be divided over 6 or 7 days of subcutaneous injection. You can increase the dose, sorry, um, at 4 to 8 weeks, every 1 to 2 months by zero point 0.1 to zero point 0.2 milligram per day. Okay, and this will depend on the clinical response and the different measurement like serum IGF. Now, let's start talking about like adrenal gland anatomy and function, as well as the disorders and how you manage adrenal gland related disorders. Adrenal gland, as you know, like it is like uh, two glands on the top of each kidney. So we have left adrenal gland, we have right adrenal gland. And when you look the histology for adrenal glands, we have a capsule, the outer layer. We have what we call it adrenal cortex, which consists of 3 layers. Zona glomerulosa, the outermost layer, zona fasciculata, which is the middle layer of the adrenal cortex, and zona reticularis, which is خلينا نقول the internal part of the adrenal cortex. Okay, as well as we have adrenal medulla. So each layer of the adrenal cortex actually responsible for production of different types of hormone. For example, zona glomerulosa, it get affected by renin-angiotensin system, which will enhance the production of aldosterone from the adrenal cortex. And you know the aldosterone is considered like responsible for sodium water retention, and of course, maintenance of blood volume and blood pressure. Um, Cortisol in general gets produced by zona fasciculator, corticosteroid under the effect of pituitary ACTH. Pituitary ACTH means adrenocorticotropic hormone, and then it will, of course, stimulate the cortisol level, cortisol production from the zona fasciculator. Also, pituitary ACTH could increase the level of androgen. Testosterone release from also the zona reticularis, which is the innermost part of the adrenal cortex. So, simply speaking, again, we have like zona glomerulosa, zona fasciculata, zona reticularis, aldosterone from the first one. We have corticosteroid, the second one, androgen from the third one. Uh, be aware that corticosteroid production depend on different enzymes. Different, it's like it takes like different steps, like 17 hydroxylase, 11 hydroxylase. Keep in mind because most of the drugs that now we will discuss in the coming slide, it could affect one or more of these enzymes. Let's start with hypersecretory cortisol disease. In this case, we have Cushing disease. We have Cushing disease. We have Cushing syndrome. So, what is the difference between Cushing disease and Cushing syndrome? Cushing disease mainly due to a pituitary adenoma. Pituitary adenoma means that you have more ACTH secretion. Of course, this will lead to more corticosteroid production, and this we call it, if the problem in the pituitary, we call it Cushing disease. Okay? If you have something else, ACTH problem or overproduction, not due to pituitary adenoma, we call it Cushing syndrome. Cushing syndrome in this case. Okay, we have other ACTH independent increase in the secretion of corticosteroid, like for example taking exogenous steroid. Somebody واحد بياخد cortisone, somebody is administering corticosteroid for a long time, they might get إيش increase in the level of corticosteroid, but it is considered like ACTH independent. Unilateral adrenocortical tumor, the problem only in the adrenal gland. So pituitary is fine. We have no issue with the pituitary gland, but the problem in the adrenal gland itself. So in this case, more corticosteroid production independent ايش على independent مستقل بشكل مستقل عن ال LCTH feedback. How to diagnose and characterize the Cushing syndrome? Simply speaking, we can check the level of corticosteroid, check the level of ACTH, do like kind of what we call pituitary magnetic MRI, overnight dexamethasone suppression test, late night salivary cortisol concentration, etc. So, with different ways, you can tell whether the patient is having Cushing syndrome or Cushing disease, and based also on clinical characteristics. What are the clinical presentation? Clinical presentation, central opacity, facial rounding, peripheral opacity and fat accumulation, myopathy, problem in the muscles, pain in muscles, osteoporosis, back pain, compression fractures, abnormal glucose level, amenorrhea or anti-hirsutism in women, lower abdominal pigmented striae, of course, red to purple, hypertension also. Look here in this picture. As you can see, this lady, she is having like moon face, big rounded face, acne, hirsutism. You see like here, also on to the right, we have fat pads, buffalo hump. They call it buffalo hump. So here, depositions of the fat and above the shoulders. We call it buffalo hump. Easy to get poses, easy to get poses. Help abdominal stretches, like we call it stretch marks here, abdominal pendulous abdomen. So in general, you see very thin here. This part, the lower part is very thin, while here we have what we call central obesity and buffalo hump, etc. So that will tell that patient maybe is actually suffering of Cushing syndrome or Cushing disease. Therapy goal: reduce mortality, normalize biochemical changes, and improve the quality of life for patient. If the reason was exogenous corticosteroid administration, then you have to discontinue or minimize and do tapering to avoid hypothalamic pituitary adrenal gland axis suppression, surgical resection in case if we have a tumor. Uh, Otherwise, you can go with pharmacological treatment. For example, one of these medication which actually inhibit the ACTH secretion, and this could be used in case that you have the problem related to ACTH secretion. So mechanism of action: bacillotide, somatostatin analog block ACTH, will lead to block the ACTH secretion from the pituitary gland, decrease corticosteroid level, etc. Um, so it is actually, which makes sense, is not effective for adrenal caused Cushing syndrome, which means that if the problem in the adrenal gland, it has nothing to do with the treatment there, because it actually target the ACTH. Means that if the problem due to pituitary issue, then you can use such a drug. Dosing up to zero point 0.9 milligram twice daily sub-Q. We can adjust the dose based on the improvement of the symptom as well as the free cortisol level in the urine. Side effect: hyperglycemia, you know, diarrhea, nausea, gallstones, headache, bradycardia, low heart rate, and hypocorticalism. Hypocorticalism, what does that mean? Mean, of course, because it does inhibit actually the ACTH secretion. And monitoring, of course, you have to do ECG, fasting blood glucose, uh, HbA1c, thyroid, liver function test, gallbladder, ultrasonography before initiating therapy. It's very important, of course. And then you have to keep an eye on this blood glucose level, liver function, etc., while the patient is taking this medication. The other drug that we could use, cabergoline, is given orally in general. Please go back and check from the um, previous slide what was the dose and the side effect. Ketoconazole, actually, this is antifungal agent, but they found that it will inhibit 11 and 17 hydroxylase enzyme, which are very important in corticosteroid synthesis. This antifungal actually, by this way, will inhibit the cortisol production. Um, 200 milligram twice daily by mouth, up to 400 milligram 3 times daily. A side effect: gynecomastia, enlargement of male breast because it affects the androgen level. Abdominal discomfort also could elevate liver enzyme in a reversible way, but be careful, sometimes it could be irreversible. Mitotan inhibit cortisol synthesis by inhibition of 11 hydroxylase enzyme again. Could be given by mouth. Of course, you can see the dose could reach up to grams, 12 gram per day. A side effect: adrenocortical atrophy, anorexia, ataxia, like this is like considered a problem with the coordinations and balance of the patient, lethargy, abdominal discomfort. Etomidate, again, similar to ketoconazole, the same mechanism of action. It's given IV. If you have problem with the oral administration, then you can go with this choice. Okay, it will inhibit the cortisol synthesis. Metapon by compassionate use only. When you have no option is working, all the options cannot be effective, then metapon could be used. Why we don't use this such a drug from the beginning due to different side effects? Okay, and this drug we keep it to the end if none of these agents actually is not working. Um, Side effect hypoadrenalism, hypertension, worsening of hirsutism, headache, abdominal discomfort. Of course, this could sometimes lead to, since you have hypoadrenalism, you need like glucocorticoid replacement if the cortisol level went below normal or physiological concentration. Please check the role of mifepristone for what we call it the hyperglycemia associated with endogenous Cushing syndrome. What is the mechanism of action for such a drug and why we use it for endogenous or hyperglycemia associated with endogenous Cushing syndrome. Last topic, we will cover the whether we have primary aldosteronism, of course, or we have what we call Addison disease. Okay, we have now. I need to talk about like two diseases, either adrenal insufficiency or hyperaldosteronism. Hyperaldosteronism, bilateral adrenal hyperplasia, aldosterone producing adenoma. So, simply speaking, you have high aldosterone, aldosterone level in your blood. So, the patient will suffer due to increase of aldosterone level in the blood, hypernatremia because it associated with sodium retention, hypokalemia, hypermagnesemia, glucose intolerance. So will lead to hypertension, muscle weakness, polydipsia, etc. How we treat? In general, we can give spironolactone because it's considered like aldosterone antagonist, okay, which is diuretics, by the way, spironolactone, potassium sparing diuretics. In this case, eplerenone, amyloid, other potassium sparing diuretic could be given for primary hyperaldosteronism. As simple as that. Now, the hypersecretory adrenal disorder or adrenal insufficiency. A primary adrenal insufficiency, we call it Addison disease. Addison disease caused by autoimmune disorder, infection, etc. Secondary adrenal insufficiency due to exogenous steroid use. This will lead to adrenal insufficiency with time. Adrenal insufficiency. So the problem now, we have impaired androgen and cortisol production. You don't have enough cortisol or androgen level in your blood. Diagnosis, of course, we will give what we call ACTH, and based on that, we should notice increase in cortisol level concentration. But if you didn't notice any increase in cortisol concentration, this will suggest like adrenal insufficiency. Clinical presentation, you have low androgen, low corticosteroid. What do you expect? You expect like elevated ACTH due to feedback mechanism. Low level will stimulate, tell the brain to produce more ACTH, hyperpigmentation, weight loss, dehydration, hyponatremia, hyperkalemia, elevated blood urea nitrogen. Why hyperkalemia, hyponatremia, you think, guys? Because Addison disease, adrenal gland insufficiency, you have problem with what? Corticosteroid, and you know that corticosteroid in general and aldosterone and other and as well as androgen, especially the aldosterone, low level of aldosterone mean low sodium, more potassium. What is the management for Addison disease? Replacement for corticosteroid. 2/3 of the dose given morning, 1/3 in the evening. Requirement per day up to 10 milligram per meter square. So if we talk about, for example, prednisolone, 2.5 milligram per day as a steroid replacement, and depend on the potency of each corticosteroid, you give the dose based on that. Fludrocortisone replace the loss of mineral corticoid, or does replaces loss of mineral corticoid. You give like up to zero point 0.2 milligram per day by mouth, and sometimes just like because for women with decreased libido, you can give dihydro epiandrosterone up to 50 milligram per day. Here, just like a comparative glucocorticoid dosing, you can see here in this slide. And I think next Sunday we will cover like the remaining part of this lecture here and there. Thank you very much.